You know that feeling when you're trying to wrap your head around something really complex, like how psychiatric medications actually affect the brain?
Hmm.
Suddenly you're navigating this maze of scientific terms, and it all feels, well, incredibly overwhelming.
Right. Well, that's precisely why we're here with this deep dive. We've taken a detailed chapter from a textbook all about psychiatric medications.
Yep, focused right in.
And our goal today is really to cut through that confusion. We're not just going to list names, we want to explore the fascinating mechanisms behind these drugs,
Exactly how they actually work.
looking at how they interact with the intricate chemistry of, your brain.
Precisely. We want to go beyond just the basic descriptions and really delve into the underlying biology.
Okay.
What are the core ideas about why these medications might be helpful in the first place?
Hmm.
And how do different categories of drugs um, target those ideas?
And maybe uncover some surprises.
Oh, definitely. We'll uncover some unexpected details along the way that should give you a much clearer picture. Okay, let's unpack this then, starting with antidepressants. When we think about depression, the idea of a chemical imbalance often comes up.
It does, yeah. It's a very common phrase.
So the textbook outlines a couple of key initial ideas here. The first is the monoamine hypothesis,
Right.
which suggests a possible shortage of certain neurotransmitters, dopamine, norepinephrine, and serotonin in the brain.
So this was the initial thought, basically. Maybe people are just low on these chemicals.
It seems like that idea of simply topping up neurotransmitter levels was a useful starting point, but, well, our understanding has become much more nuanced now.
Well, yeah. What's fascinating here is that while this hypothesis has been very influential, guiding research,
Right.
the textbook also makes a crucial point. There isn't straightforward evidence that a simple lack of these monoanes is the complete story behind depression.
So not just too little of something.
Exactly. It's more intricate than that. So that immediately makes you realize, okay, we're not dealing with a simple on-off switch. It's a much more complex system.
Right. Then there's the monoamine receptor hypothesis.
Mhm.
This proposes that when neurotransmitter levels are low, the brain's receptors for those chemicals can actually become more sensitive over time they upregulate.
Right. They become more eager, you could say, to catch any signal.
And here's where it gets really interesting. This could be a key reason why antidepressants often take several weeks before you notice a significant effect.
Yeah, that delay is a big question for many people.
It's not just about that initial increase in neurotransmitters, it's about the subsequent adjustments in receptor sensitivity.
Exactly. The brain adapting over time.
So if you've ever wondered why your antidepressant takes so long to work, the monoamine receptor hypothesis offers a compelling explanation.
And if we connect this to the bigger picture, we see that more recent research is looking even further downstream, beyond just the neurotransmitters and their receptors.
Okay, further down the chain reaction.
Yeah. The textbook mentions the idea of downstream molecular events, specifically highlighting brain-derived neurotrophic factor, or BDNF. This points to a much more complex, longer-term impact of these medications, focusing now on the sensitivity of receptors and even, the health and growth of brain cells themselves.
BDNF. That's a bit of a mouthful. What's the core significance of that in understanding depression and its treatment?
Well, the hypothesis suggests that in depression, the gene responsible for producing BDNF might be less active.
Ah, okay.
And some researchers believe that antidepressants might work, at least in part, by activating this gene. BDNF is vital for the growth and survival of brain cells.
So it's like fertilizer for the brain.
In a way, yeah. So this points to a much more complex, longer-term influence of these medications on brain health.
Which raises an important question.
Go on.
If BDNF is so important, are we just treating symptoms by boosting monoamines in the short term? Or are we also promoting healthier brain function over time with these drugs?
That's a really key question researchers are still exploring. It definitely gives you a lot to consider.
It really does. So with those fundamental ideas in mind, let's dive into the different classes of antidepressants, starting with the most well-known, selective serotonin reuptake inhibitors, or SSRIs.
The classics.
We've all heard of Prozac, Zoloft, Paxil, Celexa, and Lexapro. These are your classic examples. How do they work at a fundamental level?
Well, the name really tells you the core mechanism. SSRIs selectively inhibit the reuptake of serotonin in the synapse.
The gap between nerve cells.
Exactly, that tiny gap. Think of it like this. After serotonin transmits its signal, it needs to be cleared away. SSRIs slow down that clearance process.
So it hangs around longer.
Right. Serotonin stays in the synapse longer, increasing its availability to bind to receptors on the next nerve cell. It's like slowing down the vacuum cleaner that's sucking up all the serotonin.
Leaving more of it there to do its job.
Exactly. More opportunity to pass the message along.
Okay, that makes the basic mechanism clear. Now, the textbook mentions some interesting variations on the SSRI theme, like vilazodone, Fibrid. What makes that one stand out a bit?
Building on that basic idea.
Researchers have developed some fascinating variations. Let's take a look at vilazodone.
What's interesting here is vilazodone's dual action. Not only does it inhibit serotonin reuptake like other SSRIs.
Okay, the vacuum cleaner part.
Yes, but it's also a partial agonist at the 5-HT1A serotonin receptor.
Partial agonist. Okay, break that down.
Think of an agonist as something that activates a receptor. A partial agonist, imagine like a dimmer switch rather than an on-off switch.
Okay. Not full power.
Exactly. It only turns the light partway on, not as strongly as the natural neurotransmitter. The idea here is that by partially activating these specific receptors, it might block some of the negative feedback mechanisms.
The brain's own brakes.
Sort of, yeah. Brakes that would normally limit serotonin release, so potentially leading to an even greater increase in overall serotonin activity.
Interesting. A dual approach to boosting serotonin signaling. And then there's vortioxetine, Trintellix, which the book describes as having multimodal actions.
Right.
That sounds even more complex.
It is. Vortioxetine doesn't just work on serotonin reuptake. It interacts with several different serotonin receptor subtypes.
Like different doors for serotonin.
That's a great way to put it. These different 5-HT receptors are like different doors that serotonin can open, each leading to slightly different effects in the brain.
Okay.
So drugs like vortioxetine are trying to selectively open and close these doors for a more precise therapeutic outcome.
How does it do that?
Well, it acts as an agonist at some receptors, like 5-HT1A, a partial agonist at others, like 5-HT1B, and an antagonist, meaning it blocks the receptor.
Cuts a block in the keyhole.
Exactly. It blocks others like 5-HT3, 5-HT1D, and 5-HT7. The thinking is that by targeting this whole network of serotonin receptors in different ways, it might offer benefits for people whose depression hasn't responded well to the more traditional SSRIs. Maybe it fine-tunes the system better for them.
So these newer SSRI variations are really trained to fine-tune the serotonin system with much greater precision. Now, the book also mentions that the selectivity of SSRIs is generally a good thing, right, in terms of side effects?
Yes, that's a key advantage.
Why is that the case?
Because they primarily target serotonin and don't significantly inhibit receptors for other neurotransmitters like acetylcholine, histamine, or norepinephrine.
Okay.
This means they tend to have fewer of the side effects that we see with drugs that affect those other systems more broadly, less collateral damage, so to speak.
That makes logical sense. But the book also points out that excessive serotonin activity can still lead to problems.
Absolutely. Too much of a good thing.
What are some of those potential side effects that can arise from, well, too much serotonin?
Right. Even with their selective action, too much serotonergic activity can manifest as things like anxiety, insomnia, sexual dysfunction, and gastrointestinal disturbances.
Yeah, so common ones people hear about.
Yes. And it's really important to be aware of the more serious condition known as serotonin toxicity.
Serotonin toxicity? That sounds quite concerning. What exactly is it, and what are some of the things that can trigger it?
It's a potentially dangerous condition that can occur when serotonin levels in the brain become dangerously high.
How does that happen?
It can happen when SSRIs are taken in combination with other medications that also increase serotonin levels.
Drug interaction problem.
Precisely. The textbook provides a pretty comprehensive list of examples, including other SSRIs, SNRIs, which we'll get to, MAOIs, another antidepressant class, lithium, triptans used for migraines, buspirone, tramadol, even some over-the-counter cough and cold meds with dextromethorphan.
Wow.
And it can also occur with certain antidopaminergic drugs like tetrabenazine and some antipsychotics.
Wow, that's a significant list of potential interactions.
Yeah.
It really underscores how crucial it is for individuals to inform their healthcare providers about all the medications and supplements they're taking.
Absolutely critical. You need the full picture. The book also highlights the important role of CYP450 enzymes and how our bodies process these drugs.
The liver enzymes.
Exactly. Think of them as a liver's processing plant for medications. If another drug interferes with these enzymes, the example given is ketoconazole for CYP3A4.
Okay.
It's like slowing down the assembly line. This can slow down the breakdown of the SSRI, leading to higher serotonin levels and an increased risk of toxicity.
Right. And the reverse can happen too.
Yes. Conversely, if something speeds up these enzymes, like the antibiotic rifampin, it's like speeding up the assembly line.
So the drug gets cleared too fast.
Right, which can cause the SSRI to be metabolized too quickly, potentially reducing how effective it is. Dosage adjustments might be necessary in these situations to maintain the right balance.
That's a really important reminder that drug interactions aren't just about their direct effects on the brain. They can also involve how our bodies, metabolize these substances.
Definitely. Metabolism is key.
Now, what about when someone stops taking SSRIs? The book mentions something called antidepressant discontinuation syndrome.
Yes, this can occur when serotonergic antidepressants are stopped, particularly if it's done abruptly, not gradually.
Why abruptly?
Well, it's more likely to happen with SSRIs or SNRIs that have a shorter half-life.
Meaning they leave the body faster.
Exactly. They're cleared from the body more quickly. Paroxetine, or Paxil, is mentioned as being more prone to causing this than fluoxetine Prozac, which has a longer half-life.
Ah.
This is why a gradual tapering of the dosage is usually recommended by doctors when discontinuing these medications.
To ease the brain off it.
Right, to give the brain time to readjust to the change in neurotransmitter levels. Avoid that sudden drop.
That makes perfect sense, giving the brain the time it needs to adapt. Okay, so we've covered SSRIs in detail. The next class is serotonin norepinephrine reuptake inhibitors, or SNRIs. How do they differ in their action?
Well, as the name clearly indicates, SNRIs, such as venlafaxine, Effexor, duloxetine, Cymbalta, and desvenlafaxine, Pristiq, work by blocking the reuptake of both serotonin and norepinephrine.
Okay, 2 neurotransmitters now.
Right, thereby increasing the levels of both of these neurotransmitters in the synapse. So they're acting on 2 key systems instead of just one.
So they're hitting 2 targets simultaneously. Is there substantial evidence to suggest that this dual action makes them, more effective in treating depression compared to SSRIs?
That's a good question. The textbook points out that it's still somewhat debated in the field whether the dual action of SNRIs actually leads to greater overall effectiveness in treating depression when compared directly to SSRIs.
So the jury's still out on that one.
To some extent, yes. However, SNRIs do have established uses for other conditions. They are also commonly prescribed for various anxiety disorders and for the management of neuropathic pain.
Ah, pain relief too.
Yes. So the benefit of targeting both systems might extend beyond just addressing depressive symptoms.
Interesting. So the therapeutic reach of SNRIs seems to go beyond just depression. Now let's move on to serotonin norepinephrine disinhibitors, or SNDIs. There's only one main example provided here. Mirtazapine, Remeron. How does this particular medication work? Its name sounds different.
It is different. Mirtazapine employs a slightly different strategy. Instead of directly blocking the reuptake of neurotransmitters,
Like the SSRIs and SNRIs do.
right, it increases norepinephrine and serotonin transmission by blocking presynaptic adenorenergic receptors.
Presynaptic, meaning on the sending cell.
Exactly. Think of these specific ADO receptors as acting like brakes on the release of norepinephrine and serotonin.
Okay.
By blocking them, mirtazapine essentially takes the foot off the brake, allowing more norepinephrine and serotonin to be released into the synapse.
That's a really helpful analogy, releasing the brakes rather than just slowing down the cleanup crew. The book also mentions that mirtazapine is sometimes used in combination with SSRIs.
It is, yeah. That's quite common.
What's the rationale behind that kind of combination therapy? Are there any potential downsides?
Well, there are a couple of main reasons. One is to potentially enhance the overall antidepressant response.
Okay, bigger effect.
Right. Aiming for a greater improvement in mood than might be achieved with either medication alone. The other common reason is to help counteract some of the common side effects associated with SSRIs.
Oh, like nausea or insomnia.
Exactly. Nausea, anxiety, or insomnia. Mirtazapine can sometimes help improve sleep and appetite, which can be particularly beneficial for individuals experiencing those specific SSRI side effects.
And the downsides.
Well, as with any combination of medications, there's always the potential for increased side effects or maybe unexpected interactions. So such combinations are always carefully considered and monitored by prescribers.
That highlights the nuanced and often individualized approach to psychopharmacology. Okay, next up are norepinephrine dopamine reuptake inhibitors, or NDRIs, with bupropion, Wellbutrin, as the primary example we see. What's the unique aspect of this class compared to the ones we've already discussed?
The key thing to remember about bupropion is that, quite unlike many other antidepressants, it does not have a significant impact on the serotonin system at all.
Okay, no serotonin action here.
None to speak of. Its primary mechanism of action is to inhibit the reuptake of norepinephrine and dopamine.
Dopamine comes into play now.
Yes, leading to an increase in their levels within the brain. So it's specifically targeting a different set of neurotransmitters compared to SSRIs or SNRIs.
So it's focusing on a different set of chemical messengers. The book also mentions that bupropion, under the brand name Zyban, is used to help with smoking cessation.
That's right.
How does its action on norepinephrine and dopamine relate to its effectiveness in quitting smoking? That seems unrelated.
Well, that particular effect is linked to its additional action. Bupropion also inhibits nicotinic acetylcholine receptors.
The nicotine receptors.
Exactly, which are heavily involved in the neurobiological mechanisms of nicotine addiction. By blocking these receptors, it can help to reduce the cravings and withdrawal symptoms commonly experienced when someone stops smoking.
That's a fascinating example of a single drug having therapeutic applications for seemingly unrelated conditions based on its different pharmacological actions. Very cool.
It really shows the complexity.
Now, let's turn our attention to serotonin antagonist reuptake inhibitors, or SERIs, with trazodone, Decyral, being the main medication mentioned. The book notes that higher doses are generally needed for its antidepressant effects. Why is that?
That's correct. At higher doses, trazodone acts as both a serotonin antagonist, meaning it blocks certain serotonin receptors, and a serotonin reuptake inhibitor.
So a bit of blocking and a bit of inhibiting cleanup.
Right. However, it also exhibits significant activity at other types of receptors in the brain. What's particularly interesting is that at lower doses,
Yes.
it tends to lose much of its direct antidepressant action, but retains its effectiveness as a hypnotic or sleep aid,
So that's why it's often used for sleep.
primarily due to its antagonism of histamine receptors at those lower doses. Blocking histamine makes you drowsy.
So at lower doses, it's mainly utilized as a sleep aid. But the book also mentions a rather significant potential side effect associated with trazodone.
Priapism.
Yes, that's a serious one to be aware of.
What is the underlying cause of this? Priapism, which is a painful and prolonged penile erection, is a rare but serious side effect associated with trazodone. It is believed to be related to its potent adrenergic blocking properties.
Okay, definitely something patients need to know. Next, we have selective norepinephrine reuptake inhibitors, or NRIs, with atomoxetine, Strattera, highlighted as the first selective one approved in the U.S. How do these drugs work, and what are their primary clinical applications?
As their name clearly indicates, NRIs primarily work by blocking the presynaptic norepinephrine transporters.
So just norepinephrine reuptake.
Exactly. Inhibiting the reuptake of norepinephrine back into the nerve cell, atomoxetine is primarily prescribed for the treatment of attention deficit hyperactivity disorder, or ADHD.
Not depression.
Not primarily. It's often used in situations where stimulant medications for ADHD might not be suitable or well tolerated. Interestingly, the textbook points out that it has not demonstrated a significant benefit for treating depression itself. It's a good reminder that even within seemingly similar classes of drugs, targeting just one neurotransmitter might work for one condition but not another. There can be notable differences.
That's an important point. Selectivity doesn't always translate across different conditions. Now we're moving into some of the older classes of antidepressants, tricyclic antidepressants, or TCAs. The book mentions they are more accurately referred to as cyclic antidepressants, or CAs.
Right, a broader term.
What's the reason for this more inclusive terminology?
Well, the original TCAs were characterized by a specific three-ring chemical structure, hence the name tricyclic.
Makes sense.
However, newer antidepressant medications that function through similar mechanisms might have a four-ring structure instead. Therefore, the term cyclic antidepressants is considered more accurate and encompassing.
To cover both 3- and 4-ring structure.
Exactly. To include all drugs that share this general mechanism of action. Common examples people might know are amitriptyline, Elavil, and nortriptyline.
And how do these cyclic antidepressants exert their effects? The book mentions they primarily affect norepinephrine and, to a lesser extent, serotonin levels.
That's correct. Their main mechanism involves blocking the presynaptic transporter proteins responsible for the reuptake of norepinephrine and, yes, to a lesser degree, serotonin.
So similar to SNRIs, but maybe less balanced.
Sort of. By blocking the norepinephrine transporter, they prevent norepinephrine from being taken back up into the nerve cell after it's sent its signal, thus increasing its concentration in the synapse.
Okay.
The book also highlights that this blockade prevents norepinephrine from being broken down by the enzyme MAO, further contributing to the increased levels. So it's hitting it in two ways, really.
Now, the book notes that TCAs, or CAs, have multiple actions that can be beneficial in severe depression and chronic pain.
Yes, they can be quite effective for tough cases.
But they also acquired the somewhat unflattering nickname of dirty drugs due to their broader range of side effects.
That term comes up.
What's the basis for this dirty moniker?
Well, the term dirty in this context refers to the fact that TCAs are not as selective in their actions as many of the newer antidepressants. They're less targeted.
They hit more things.
Exactly. They tend to interact with multiple different types of receptors in the brain in addition to the norepinephrine and serotonin transporters. For example, they block muscarinic receptors,
Which
can lead to anticholinergic side effects like dry mouth, blurred vision, constipation, and urinary retention, kind of drying things out.
Okay.
They also block H1 histamine receptors, which can cause sedation and weight gain, and they have a strong affinity for adrenergic receptors,
Needing to.
which can result in dizziness and a drop in blood pressure, increasing the risk of falls, particularly in older adults.
So, while they can be effective, they come with a wider array of potential side effects compared to the more selective antidepressants. The book also emphasizes the potential danger of overdose with TCAs.
Yes, this is a very serious concern.
Why is that a particular concern with this class?
TCAs are highly lipid-soluble, meaning they dissolve well in fats.
Okay.
And they are absorbed rapidly into the bloodstream. This means that in an overdose situation, they can quickly reach toxic levels within the body.
That sounds dangerous.
It is. This can lead to serious and potentially life-threatening cardiotoxicity, heart problems, as well as other severe symptoms, often before medical help can even be obtained.
Wow.
And this risk is particularly concerning in older adults who may have slower rates of drug metabolism and elimination.
That's a very important warning to be aware of. Okay, finally, in the antidepressant category, we have monoamine oxidase inhibitors, or MAOIs.
Another older class.
To really understand how these work, we first need to have a clear understanding of what monoamines and MAO actually are. Can you break that down for us?
Absolutely. Monoamines are a class of organic compounds that includes several important neurotransmitters: norepinephrine, epinephrine or adrenaline, dopamine, and serotonin.
The ones we've been talking about mostly.
Right. Plus, various other drugs and certain substances found in food. Monoamine oxidase, or MAO, is an enzyme in the body that plays a crucial role in breaking down these monoamines.
Okay, the cleanup crew again, but a different one.
A different kind, yes. It breaks them down inside the nerve cell usually, or elsewhere in the body. MAOIs are a class of drugs that work by inhibiting the activity of this enzyme.
So by inhibiting MAO, MAOIs prevent the breakdown of monoamines, which in turn leads to higher concentrations of these neurotransmitters in the brain.
Exactly. More neurotransmitters available for release.
The book mentions that they can be effective for treating intractable depression, cases that haven't responded to other treatments.
Yes, they can be very powerful for resistant depression.
Why aren't MAOIs used more frequently as a first-line treatment then?
Well, while MAOIs can be quite effective, SSRIs and SNRIs are generally preferred as initial treatments due to the potential for significant interactions.
Okay, interactions again. What kind?
Particularly the risk of vasopressor affects things that raise blood pressure when MAOIs are combined with sympathomimetics.
The substances that stimulate the nervous system.
Right. The most serious of these potential interactions is a hypertensive crisis.
A hypertensive crisis that sounds very dangerous. What are some of the common triggers for this kind of reaction in people taking MAOIs?
A hypertensive crisis can be triggered by taking over-the-counter medications that contain pseudoephedrine.
A common decongestant.
Yes, found in many cold and allergy remedies. It can also be triggered by consuming foods and beverages that are high in tyramine.
Tyramine, what's that?
It's an adrenergic monoamine found naturally in certain foods. It's typically found in aged and fermented foods, like aged cheeses, cured meats, like salami or pepperoni, certain types of alcoholic beverages like red wine or tap beer, soy sauce, sauerkraut, things that have been aged or fermented.
So individuals who are taking MAOIs need to be extremely vigilant about their dietary choices and any other medications they might be taking.
Absolutely. This dietary restriction of tyramine must be strictly adhered to.
And not just while taking the drug.
No, not only while a person is taking MAOIs, but also for a period of about 2 weeks after they have stopped taking them.
Why 2 weeks after?
To allow the body sufficient time to resynthesize the MAO enzyme. The drug's effect lasts longer than the drug itself is in the system.
Okay.
The book does mention the MAOM patch, which delivers the MAOI selegiline through the skin.
A patch form.
Yes, and it has been associated with somewhat fewer hypertensive effects compared to oral MAOIs like phenelzine, Nardil, and tranylcypromine, Parnate, especially at lower doses.
But still need to be careful.
Yes, even with the patch, dietary precautions are still generally necessary, especially at higher patch strengths.
That's a really comprehensive overview of the different classes of antidepressants and their mechanisms.
Wow. Now let's shift our focus and talk about anti-anxiety or anxiolytic drugs.
Okay, moving on to anxiety. The book begins by noting that antidepressants are frequently used in the treatment of anxiety disorders. We touched on this with SNRIs.
We did, yeah.
What's the underlying reason for this overlap in treatment? Why use an antidepressant for anxiety?
Well, as the textbook points out, there is a significant degree of overlap in the symptoms. The neurotransmitters involved, especially serotonin and norepinephrine, and the brain circuits implicated in both depression and various anxiety disorders.
Oh, shared biology underneath.
Exactly. Because of this shared neurobiological basis, SSRIs are commonly prescribed to treat a whole range of anxiety disorders: panic disorder, generalized anxiety disorder, GAD, OCD, PTSD, social phobia.
Quite a list.
Yeah. And the SNRIs, venlafaxine, and duloxetine are also frequently used in the treatment of GSD, so the same medications that help to elevate mood can often also help to alleviate anxiety symptoms.
So the same medications that help lift mood can also help calm anxiety in many cases. Now, what about buspirone? Buspar. That's another medication specifically mentioned for anxiety relief.
Right, Buspar.
How does its mechanism of action differ from the antidepressants we've been discussing?
Buspirone is interesting because it can reduce anxiety symptoms without typically causing the immediate sedative and mildly euphoric effects that are often associated with benzodiazepines.
So, less sedation.
Generally, yes. While its precise mechanism isn't fully understood, it is known to have a high affinity for serotonin 5-HT1A receptors.
Those receptors again.
Yes, which, as we discussed earlier in the context of antidepressants and some newer SSRIs, are also thought to play a role in mood regulation and anxiety.
Okay.
Importantly, while combining high doses of buspirone with alcohol is generally advised against, it does not carry the same risk of addiction and dependence associated with benzodiazepines.
Oh, that's a big difference.
That lack of addiction potential is a really significant difference to keep in mind. It takes longer to work, though, often weeks, like SSRIs.
That lack of addiction potential is indeed a very significant difference and a key advantage in certain situations. Now, let's talk about benzodiazepines themselves, such as diazepam, Valium, clonazepam, Klonopin, alprazolam, Xanax.
The benzos.
Right. The book mentions that they were once very commonly prescribed for anxiety, but are now used less frequently, or at least more cautiously.
Yes, there's been a definite shift.
What are the primary reasons behind this shift in prescribing patterns?
The main reasons are growing concerns about the development of tolerance with long-term use.
Meeting more for the same effect.
Exactly. Also, the significant potential for abuse and dependence, and more recent research suggesting a possible link between long-term benzodiazepine use and an increased risk of dementia.
Oh, wow, dementia too.
It's an association being studied, yes. Due to these concerns, benzodiazepines are now generally recommended for short-term use only for managing acute anxiety.
Like a panic attack, maybe?
Yes, or a very stressful short period. And they should typically be avoided in combination with opioid medications due to the increased risk of dangerous respiratory depression.
Okay, so short-term, acute situations.
They can be very effective for providing rapid relief from acute anxiety, but they come with some considerable downsides, especially with prolonged use.
So, they can be effective for acute anxiety, but come with those significant downsides. How do benzodiazepines actually exert their calming effects in the brain? What's the neurochemistry?
They work by enhancing the activity of GABA,
GABA.
which is the brain's primary inhibitory neurotransmitter, the main calm-down signal.
Okay.
Benzodiazepines bind to specific sites on the GABA receptor complex, which makes the receptor more responsive to GABA when it binds.
So they boost GABA's natural effect.
Exactly. They potentiate GABA's effects, leading to a calming down of nerve activity in various parts of the brain. The textbook even mentions how different benzodiazepines might bind slightly differently, perhaps explaining subtle variations in their effects.
Interesting. The book mentions that benzodiazepines have limited direct toxicity in the absence of GABA. Why is that?
Because they don't directly inhibit neuronal firing themselves, they only amplify the inhibitory effects of GABA.
So if GABA isn't there,
Then the benzodiazepines themselves don't have much of an effect on neuronal activity on their own. They need GABA to work with.
okay.
However, their sedative and hypnotic effects do put patients at risk of developing tolerance, as we said.
Needing higher doses.
Right, and abrupt discontinuation can lead to unpleasant and potentially dangerous withdrawal symptoms.
Now, the book makes a distinction between benzodiazepines that have predominantly hypnotic or sleep-inducing effects versus those more focused on reducing anxiety without as much sedation.
There are differences.
Can you provide some examples of each of these types?
Certainly. Benzodiazepines like flurazepam, Delmane, and triazolam, Halcion, tend to have stronger effects on inducing sleep. They're often marketed as sleeping pills. On the other hand, drugs like lorazepam, Ativan, and alprazolam, Xanax, are often preferred for their anxiety-reducing properties, although they can definitely still cause drowsiness in many individuals.
The book also connects their GABA-enhancing action to their effectiveness in treating seizures and alcohol withdrawal. How does that mechanism help there?
Well, in both seizures and alcohol withdrawal, there's often an imbalance in the brain. Too much excitation, not enough inhibition.
Okay, brain activity is too high.
Exactly. Excessive excitation plays a significant role. By boosting the inhibitory effects of GABA, benzodiazepines can help to dampen down this excessive neuronal activity, which is why they can be effective in managing these acute conditions.
But the book also includes a warning about the significant danger of combining benzodiazepines with other central nervous system depressants.
Yes, a very important warning.
Why is that combination so risky?
Combining benzodiazepines with other substances that also depress the central nervous system, like alcohol, opioid pain medications, or even older antidepressants like TCAs,
Right.
can have a synergistic effect.
Meaning more than just adding them together.
Yes. Their combined inhibitory actions on brain function can be much greater than the sum of their individual effects. This can potentially lead to dangerously slowed breathing respiratory depression, which can be life-threatening.
That's a really critical point about potential interactions that people need to be acutely aware of. The book also mentions the impact of benzodiazepines on motor ability and judgment.
Yes, definitely affects those.
What are the practical implications?
Well, because they can depress overall brain activity, benzodiazepines can definitely impair coordination, reflexes, and attention.
So driving is a bad idea.
Absolutely. Patients are strongly cautioned about engaging in activities that could be hazardous if these functions are impaired, like driving or operating heavy machinery. They should also exercise caution when making important legal or financial decisions.
Whose judgment might be off.
Exactly. Judgment might be affected. Ataxia, which is difficulty with coordination and balance, is also a relatively common side effect,
Why ataxia?
likely due to the presence of GABA receptors in the cerebellum, a brain region crucial for motor control.
Okay, so benzodiazepines definitely have their place, primarily for short-term relief of severe anxiety. But they come with a significant set of risks that need careful consideration.
A very careful balancing act.
Now, let's move on to short-acting sedative hypnotic sleep agents, often referred to as the Z-hypnotics, like zolpidem, Ambien, Zaloplan, Sonata, isoprolol, Lunesta.
The Z drugs, yeah.
How do these differ in their action compared to the traditional benzodiazepines we just discussed?
The Z hypnotics are designed to be more selective in their action on the GABA receptor.
More targeted again.
Yes. They primarily target GABA receptors that contain specific subunits, AQ1 subunits, which are thought to be more specifically involved in producing sedation.
So they aim just for the sleep part of the GABA receptor.
That's the idea. This greater selectivity allows them to exert their sedative effects without having the broader range of effects often seen with benzodiazepines.
Like muscle relaxation or anti-anxiety effects.
Right. Less significant anti-anxiety, anticonvulsant, or muscle relaxant properties compared to benzos. So they are more targeted towards inducing sleep.
So more targeted towards sleep without the wider range of effects. Finally, in the anti-anxiety sleep category, the book mentions melatonin receptor agonists, with Remelty and Roserum being the primary example.
Roserum.
How does this type of medication work to promote sleep? It sounds different again.
It works very differently. Romelantine works by specifically binding to and activating melatonin receptors in the brain, mimicking the effects of our body's natural sleep hormone, melatonin.
working with the natural sleep hormone.
Exactly. It exhibits a high degree of selectivity for melatonin 1 receptors, thought to regulate sleepiness, and melatonin 2 receptors involved in regulating our circadian rhythms, our internal clock.
So it's a more direct approach to influencing the body's natural sleep mechanisms rather than general sedation.
Precisely, a different strategy altogether.
Okay, so a more natural approach to sleep regulation by targeting the melatonin system. Now let's move on to mood stabilizers, which are primarily used in the treatment of bipolar disorder.
Right, for managing the highs and lows.
The first one we'll discuss is lithium. The book mentions that its precise mechanism of action is not yet fully understood.
Which is surprising, right? It's been used for decades.
Very surprising for a drug used so long. What are some of the things we do know about how it works to stabilize mood?
Well, while the exact cellular and molecular mechanisms remain somewhat unclear, the textbook highlights that it appears to influence multiple steps in intracellular signaling pathways within brain cells.
Inside the cells.
Yes. Specifically, it seems to affect second messenger systems, systems that relay signals from the outside of the cell to the inside, leading to alterations in processes mediated by calcium and protein kinase C.
So broad effects on how cells signal internally.
Pretty much. It has a broad impact on various cellular processes, which likely contributes to its mood-stabilizing effect.
The book also mentions that lithium has a relatively low therapeutic index.
Yes, a narrow window.
And that regular monitoring of blood levels is essential. Why is this careful monitoring so critical?
Because lithium's effects on electrical conductivity in the body mean that the range between a dose that is therapeutically effective and a dose that can become toxic is quite narrow.
Not much room for error.
Exactly. Therefore, regular monitoring of lithium blood levels is absolutely crucial to ensure patients are getting enough to manage symptoms effectively, but not so much that it reaches a dangerous level.
And kidney function is important.
Very important. Lithium levels are significantly influenced by kidney function as the kidneys excrete it. So kidney health is a key factor.
And the book also notes that changes in sodium levels and hydration status can affect lithium levels. How does that interaction occur?
The kidneys play a key role in regulating both sodium and lithium levels, and they handle them somewhat similarly. When sodium levels in the body are low, maybe due to heavy sweating, illness, or certain diets, the kidneys will try to retain more sodium to maintain balance.
Right.
And in the process of doing so, they can also retain more lithium, which can lead to an increased risk of lithium toxicity.
So low salt means higher lithium risk.
Correct. Conversely, if there's an excess of sodium, the kidneys might excrete more lithium along with the sodium, potentially lowering lithium levels and reducing its effectiveness.
So consistency is key.
Very much so. Maintaining a consistent sodium intake and staying adequately hydrated are very important for individuals taking lithium. The book also points out the risk of kidney and thyroid problems with long-term lithium use.
So more monitoring needed.
Yes, ongoing monitoring of those organ systems is necessary.
Definitely a medication that requires very careful and ongoing management. Now let's turn our attention to the anticonvulsant medications also used as mood stabilizers, starting with valproate Depakote or Depakine.
Right, originally an anti-seizure drug.
The book mentions it can be an option for bipolar disorder, particularly when lithium isn't effective. How might valproate work as a mood stabilizer?
One of the potential mechanisms discussed is that valproate may exert its mood-stabilizing effects by inhibiting enzymes involved in the breakdown or catabolism of GABA.
GABA again, but inhibiting its breakdown this time.
Yes. By slowing down GABA breakdown, it could lead to an increase in GABA levels in the brain, which in turn could reduce overall neuronal excitability. Less excitability, more stability.
That makes sense. The book also includes some significant black box warnings for valproate,
Yes, very serious ones.
including potential liver problems, risks to unborn babies if taken during pregnancy, and pancreatitis. Those sound very serious.
They are indeed significant risks. Hepatotoxicity or serious liver damage is a concern needing careful monitoring. Valproate is also teratogenic, meaning it can cause serious birth defects if taken by women during pregnancy. This is why the book strongly emphasizes the critical need for effective birth control for women of childbearing age taking valproate.
Absolutely critical.
Pancreatitis, inflammation of the pancreas, is another rare but potentially serious side effect. The book also notes an important drug interaction. Valproate can increase the concentrations of another mood stabilizer, lamotrigine,
Oh, okay.
requiring potential dosage adjustments when used together.
Which brings us to our next anticonvulsant mood stabilizer,
Well,
lamotrigine, or Lamictal. The book specifically mentions it's considered effective for the depressive phase of bipolar disorder.
Yes, particularly helpful for bipolar depression.
What is its primary mechanism of action believed to be?
Lamotrigini's primary mechanism is thought to be the inhibition of the release of glutamate and aspartate.
Okay, different neurotransmitters, now excitatory ones.
Exactly. Glutamate and aspartate are the main excitatory neurotransmitters in the brain. By reducing the release of these GO signals, it's believed to help stabilize mood, particularly preventing or treating the depressive episodes common in bipolar disorder.
So mood stabilizers as a class appear to work through a variety of different neurochemical mechanisms. Lithium affecting intracellular signaling, valproate boosting GABA, lamotrigine reducing glutamate release.
It really highlights the complex nature of mood regulation, doesn't it?
Definitely. And the challenges in treating disorders like bipolar disorders.
Exactly. Lithium, valproate, lamotrigine each have distinct primary actions and a range of other effects. It reflects the multifaceted nature of bipolar disorder and the different ways we can attempt to modulate brain activity to achieve greater mood stability.
Well, we have certainly covered a tremendous amount of information in this deep dive into the world of psychiatric medication.
We really packed it in.
It's abundantly clear that these drugs are incredibly complex, each with its own specific and often intricate way of interacting with the delicate chemistry of our brains.
Yes, and I think a key takeaway for you should be that our understanding has really evolved beyond those simplistic notions of just chemical imbalances.
Right, it's much more than that.
We've explored the nuances of receptor interactions, the significance of downstream molecular events like BDNF, and the delicate balance between various neurotransmitter systems.
So as you think about these different mechanisms, it really makes you appreciate why the choice of medication for a specific individual is such a personalized process.
Absolutely. It's not one size fits all.
It's clearly not just about a single neurotransmitter being out of whack. It's about a much more intricate and dynamic interplay of biological processes within the brain. And when you consider all of this, what does it tell us about the fundamental biological basis of mental health conditions themselves? It really underscores just how complex these disorders of the brain truly are.
Precisely. And if we consider this ever-increasing understanding of these intricate neurochemical processes, it leads us to a final provocative thought for you.
Okay, leave us with something to think about.
With all of this rapidly expanding knowledge, what exciting new and even more targeted treatments might the future of psychiatry hold? The field of neuropharmacology is constantly evolving.
Always changing.
And our growing understanding of the brain's incredible complexities offers truly exciting possibilities for developing more effective and personalized interventions for a wide range of mental health challenges. Keep exploring.